happened here. So Trong was trying to drive out those two pathogens, and he was doing his best. He was trying all sorts of tricks, and every time he ended up hitting her. So that means your own response, your body's response is starting to harm you. That is the concept of SARS. Okay? It's not only about directly what the pathogens have done to you. Okay? That occurs in any rate. If you have a localized infection, their too cells die because of the toxins produced by. We talked initially about toxins. We said that exotoxins are produced by gram-positive bacteria. They can directly kill cells. Indirectly, they help the bacteria to spread. So that is one sort of injury. And the other type is endotoxins, which evade bacteria and evade bacterial defenses. They too can cause several deleterious effects. But ultimately, the injury they cause, the bacteria cause, is there of course, but the response to is harmful, and that is known as SARS. And that SARS cause MORS. So we'll see a practical example here. We'll see this patient is a young boy. He's quite young, and I think he was around 18 years old, and he was playing football, and he had this injury. This patient was admitted under NETL last week. So this is a real life example. So he had just this cellulitis. Doesn't look very frightening. Okay, of course the picture is not ideal. It was spread up to the knee almost, and he had fever. So let us see. Sorry, initially he had fever. When we got the patient, he had these features. See, his leukocyte count is 15,700, and so this was the dressing we had done, and if you watch very carefully, you'll see that his respiratory rate is quite high. So he's breathing rapidly. And this is the pulse oximeter. It's showing a pulse rate of 100. So see, the pulse rate is 100. Okay, so what do we have? So we have the patient is affected. There is no fever, but there is leukocytosis, and there is tachypnea, and there is tachycardia. So by definition, this patient has SARS. So you understand how objective this criteria is. It doesn't need a professor or an assistant professor, associate professor to diagnose this. When you become interns, you too can diagnose whether the inflammation is severe. Okay, and as we've said repeatedly, why is that important? It is important because if this is neglected, if the treatment is incomplete or the treatment is not properly done, then the patient will go into multi-organ failure. Now see what happened. See what happened. These are the organ systems which are affected. Okay, please, if possible, keep a screenshot of this slide. So the first we check is CNS. The patient is disoriented, restless, unresponsive, or very quiet. Either the patient is very restless or very quiet and drowsy. So we generally, when we were students, these concepts weren't around, and we used to think this fellow is, he's an alcoholic, or he takes some other substance abuse. He's into substance abuse. So that's why, because he's not getting all that, that is why he's shouting, or he's just otherwise a rude fellow or something. Okay, so this was not defined. It was not known that this represents a part of a multi-organ function. Now, second, if the CVS is affected, then there will be, these are the clinical signs, and there will be tachycardia and hypotension. Okay? And if there is dyspnea and tachypnea clinically, then the signs are tachypnea. So see, these are also signs of SARS. But as they progress, then they show that the organs are failing. So we had defined sepsis as SARS with documented infection. Now, if the patient starts to have all this, if the liver is affected, then there is jaundice. Clinically, you see icterus, and the LFT will be altered, and the P time will be prolonged. Okay, the P time means the prothrombin time is prolonged. So all these are markers of these objective markers of dysfunction. So again, you don't really need a senior to tell you all this. You have the report, so you see that the patient is, until the patient has an infection in the leg and he's shouting and screaming and he's requiring to be tied down to the bed. So that how does it correlate? So that is the way it correlates. It's dysfunction due to MODS. Okay, that sepsis is causing SARS, and ultimately, since it's not fully controlled, it is causing this CNS dysfunction. If the patient has hypotension, we had defined this earlier. So sepsis with hypotension is known as septic shock. If the patient has what happens is oximetry. That means the patient has tachypnea. So that is clinical tachypnea, dyspnea. But when we check the pulse oximeter, we find that all of you must be aware of the pulse oximeter now that because of this COVID. So the SpO2 starts to fall. If you do an EKG, you find that more and more oxygen is being required to maintain the partial pressure of oxygen. Again, hepatic icterus is clinical. You see that the sclera is yellow, and when you carry out the liver function test, you find that the bilirubin is raised and the P time is also raised because the clotting profile becomes worse. In the abdomen, there are no investigations per se, but you can, the abdomen becomes distended, there is vomiting, and all we have put in a rice tube, there's an increased aspirate from it. Okay, that implies that the gut is not working properly. This ileus, paralytic ileus. The kidney, very easy to measure because we have oliguria and high colored urine, and the urine volume becomes less than 0.5 ml. The normal, by the way, is 1 ml per kg per hour, and it becomes less than 0.5 ml per hour. There may be even total failure with fluid retention, and urea creatinine is the easy way to measure renal function. And finally, hemostasis, again, bleeding time, platelet, prothrombin time, APTT, platelet count. These all, if they are clinically, if it's very severe, there could be bruising, overt bleeding from these sites, or these are the measures of the bleeding tendency. So any or all, if there's just even two or more of these organs, if the patient is very restless plus he has hypertension, or the patient there is dyspnea and there is icterus. Okay, you don't know which patient which organ will start to fail. So if just two organs are found to be dysfunctional, then you define it as MODS. So again, I'll show you a clinical example. Again, this patient is a very recent patient of mine. He came to our outdoor on the 10th of May, and he had just this swelling. Okay, he had some fever, and there wasn't much else. In the on the back, there was some, and he gave a vague history, used to have itching. So the hygiene wasn't very good. So we started him on antibiotics, and on that, this was on the first day, and then by the fourth day he started developing some ulcers. This date is actually wrong. This was 10, and this was 4 days later. On the 8th, 9th day, this had become severe. Okay, he came to us on the 3rd or 4th day. This was all there was. Then it started to progress, and then on the 10th day, this is a condition called necrotizing fasciitis. I believe I showed you a video of necrotizing fasciitis of the scrotum, which is known as Fournier's gangrene. But Fournier's gangrene is like the classical condition is restricted to the scrotum, but generally that used to be thought of as a particular type of infection. That is not true. It is classified under necrotizing fasciitis. Okay, it's very dangerous. It used to be thought to be rare. I am getting frequent cases nowadays. Even in my unit, I have dealt with in the COVID period. I don't know whether it's linked with COVID or not. Many of my patients were negative, so I can't say it's directly related to the virus. But the fact remains that over the last 2 years, I've seen more cases than I've seen in my previous 25 years of service. So whatever the reason may be, so this is a severe diffuse sort of infection, and it is causing. So it was causing SARS, okay, and at this stage it started causing a MODS also. So what was the evidence of MODS? See, there was oliguria, high colored, this urine volume, this was in 5 hours, okay. So this indicates that there is renal dysfunction, and there was also a rise of creatinine. Okay, there were several parameters, but I am showing you the reports. So this is what we did. So how do we treat SIRS? Okay, the idea here today is not to teach you the treatment, but still, in appendicitis, if the patient is having SIRS with appendicitis, the obvious treatment is appendicectomy. If there's a liver abscess, you drain the abscess. That will generally, along of course with antisystemic antibiotics. Now here the treatment is difficult because the lesion is not localized like an abscess. So the surgeon has to be bold and cut out a lot of tissue. You drain the tissue. Even there's no pus, it is difficult to just make long incisions down to the fascia. Even though it's called fasciitis, it's actually limited to the subcutaneous tissues and skin and subcutaneous tissues. So those have to be removed. I believe I use the term debrided. Debrided means removal of debris, of broken, dead material. So this is a very cruel operation. Okay. See the picture. See, there was the skin on the right side had become involved. So this whole area was widely debrided. Okay, so this is called source control. So you have to remove the infected tissue so that the response starts to, when the body senses that there is less inflammation, less infection, then the response also starts to go down. So how did it affect the patient? So first debridement was done on the 15th of May. At that time the creatinine was 2 and the INR, this is normally should be within 1.25, so it was 1.31. That means that there was a tendency towards hypocoagulability. Second debridement was done on the 17th of May and the creatinine fell 1.4, 1.27. On 19th, 20th, we did not do the serial, but these results came back normal. Creatinine, you know, it's 0.6 to 1.2. So this had gone. This is a clear evidence of creatinine. If you could see the urine, I didn't show you all the urine volumes. We didn't take a picture of all that. But the creatinine level was definitely in the normal range initially. Then it started as the patient the disease came under control. Gradually, the renal function improved, and this patient survived and went home. Okay, so his antibiotic obviously was the organism was asymptomatic and sensitive to polymyxin B, so this was also sent. CRP is not part of your organ MODS score, but it is a non-specific marker of inflammation. Normally it's 0.6. This patient with a CRP of 6.5, which is significant. So see, this is how these are important. Okay, they are just learned reports, but they can tell you that whether the patient is responding to your treatment or not. For a surgeon, doing an appendicectomy or doing a cholecystectomy is relatively easy. So it's so easy to understand. This organ is inflamed, this is infected, this has to remove. Full stop. The patient gets well. That was how we treated things. We used to think that we could treat everything by surgery. Okay, when we were students, so now we realize that it's not like that. If there is inflammation, if it is severe, it will cause multi-organ dysfunction. So it's not only about just removing something. Okay, the whole overall concept of SIRS, that the inflammation of the severe inflammation may cause a severe response, and that severe response itself, even though it's supposed to be obviously meant to be beneficial for the body, can cause harm and multi-organ dysfunction. So when we were students, if the patient had appendicitis with jaundice, we were told that probably that severe appendicitis led to formation of pus, and that pus traveled through the portal vein and it lodged in the liver, causing liver abscess. Okay, so now we know that is not true. Okay, that yes, that can occur, but as I said, I in my 27 years of service, I have seen only one case of appendicitis with liver abscess with jaundice. Okay, so but I have seen many cases of complicated appendicitis with jaundice, meaning that it is not due to the bacteria entering the liver through from the appendix. Okay, it is because of the organ dysfunction. So all these mediators which are circulating in the blood, harming the various organs and causing organ dysfunction. The jaundice is not due to that. Okay, it is due to that those circulating substances rather than directly bacteria from an infective source. Okay, please do remember this. So even a patient who has polytrauma, who has fallen from the 8th floor of a building, he has not yet developed infection, he can also have jaundice. Okay, so this jaundice is not directly due to the bacteria itself. Okay, so I took time off from my today's topic just to show you a practical example of how SIRS and NODS occur and how they are important in our management. Okay, so if you have any queries or feedback, Please, this is my WhatsApp number, this is my email, so please do communicate with me. Right, so now we go on to the topic of lumps. Right, so we are starting very late. Still, I'll try to cover some of it so that we can finish it by the next day. Hello, can you hear me?
Yes, sir.
Hello. Okay. So, lump, this these are this is one of the favorite complaints of chief complaints for a surgeon, because see, pain is the most common important complaint, but it's so subjective. So patients like can have pain due to anything, like they are some people are hyper-excitable and if they have an ant bite them. I remember being in the emergency once in my school, in my college tenure, and then a patient came from I was in NRS, and the patient came from one of the local slums, and he was very worried. He used to sleep beneath the flyover, and an ant bit him. So see, these are actually manifestations of social problems and personal problems. Okay, and he was saying I'll die and this and that. And I have seen people who have been trampled by, literally, I worked in the periphery districts, and I've seen people. I've seen a person bitten by a tiger. I've seen a person trampled by a elephant. Okay, with a broken leg, and he had a stoic expression. Is it pain? Yes, a little. So see, this varies. This is so subjective. Your mental state, your upbringing, a lot of things. So and pain is very difficult to describe sometimes. What type of pain? So we are unhappy with pain. Okay, it is there. It's a pain. Okay, but we are unhappy with pain. This we are very happy with. Lumps we are very happy with, because lump means there's definitely there. Of course, you can see it. Sometimes patients complain of a lump and you can't see it or feel it. Okay, that's a different story. But if you can really see or feel a lump, you are much happier. Okay, because it's a physical thing. It's something definite, and it narrows down the. It definitely helps narrows down the possibilities. So okay, so we start with how to take history of a lump. So it starts with number. Okay, so we say a lump, but if the patient may have 2 or 3 lumps, even that helps. Okay, we will see how. The site, obviously, when you have a lump in the epigastrium, you're not thinking of a brain tumor. So site, obviously, you think of all the organs from skin to bone in that region, and and by the way, always remember that we make a diagnosis often because something is common. So if there's a lump on the dorsum of your hand, even if I don't see it, if there are 100 people with lumps on the dorsum of their hand, the chances are the 70 to 75 to 80% will be ganglion. Okay, so ganglion, all of you, I'm sure you all know that it's a secretion, a collection of mucin from the tendon sheets or the accompanying small joints of the wrist. So just sight can tell you what the lump is. That doesn't mean that you can't have a nodular melanoma on the back of your wrist, or a sebaceous cyst, or any of the other lumps, a fibroma or a neurofibroma. It's not saying that. It's just saying that a lump at that particular site is most likely to be this, and this most likely this phrase is very important in diagnosis in our at this time. If a patient is having respiratory distress and fever, so obviously we think of COVID because it's now an epidemic. It's systemic. So just the frequency of something often helps us in making a diagnosis. Size, obviously, there are lesions which are very small. Normally, even the full size of that lump is in that disease is small, in some they're very large. So size matters. Shape, again, depending on the organ, it matters. Course. So of all these, perhaps this is the most important. Okay? Course meaning how it started, how it progressed, if it's increasing and decreasing, it's increasing steadily. That is known, and that is perhaps the most important part of the history of a lump. And finally, the associated complaints. Okay, painful, that's ulcerating or not. Okay, causing some secondary effects. So all these are important. So we get on to the pictures. Right. So number. Okay. So this is a sebaceous cyst. Okay, on the back. Now, generally, sebaceous cysts can be multiple. So this particular person had one. It's very unlikely to be in neurofibromatosis is like it could be tens of them. Okay, so just one or a few you think of that makes it limited to a certain number of diagnoses. Okay, lipomas generally you have one, but there can be diseases in which there are multiple lipomas. Neurofibroma again, it's usually multiple. Okay, so if you have one, you search for it, you often get another two or three at least. Okay, most people who come with neurofibromas. Neurofibromas, by the way, are tumors of the nerve sheaths, okay, of the peripheral nerve sheaths. So they are quite often multiple. But if it's one, then you again think of certain things. So number. See, this patient is my patient. Okay, I'm both sorry for her, and in a sort of I'm proud that I'm able to take care of her. See, she is covered with this. Okay, she's covered. I can't remember seeing any part of her body not covered. Within her hair, scalp, legs, genitalia, back, everywhere, eyelids even. Okay, and poor thing, none of she's. It's not. These are all neurofibromas. Okay, I don't think there is any other patient in the world, person in the world who can compare with this. Okay, and she lives quite nearby. And the problem she comes with is that when she lies down, or every 4 or 5 weeks, some of these become ulcerated due to friction, and she comes here. We can't even start an IV fluid because we can't see the veins even. So somehow we start a small, get a peripheral vein started fluid, and we remove some of them, send them for biopsy, just in case they're malignant, but they aren't malignant. And I can't imagine how she spends her week. I don't know what I would have done if I were suffering from this. Okay. Just thousands of neurofibromas. Okay. So number, as I said, this is an extreme example. Most people who come with neurofibromas usually have, say, 5, 7 lumps, and they feel one, they get very scared, then they start doing bathing or something, they feel properly, very carefully throughout their body. So quite often, most occupants lumps are palpable. So that is the usual history number. So this is that unfortunate lady. You can see this is all over her body, all over. Okay, so site. Okay, site is important because see, this is at the angle of the mouth. All basal cell, 90% of basal cell carcinomas occur along above a line, at or above a line, extending from the tragus to the angle of the mouth. Okay, so just the fact that it looks ulcerated, and she is an elderly person. Obviously, age, sex, we know that in history everything is important. So an elderly person with a lump, with an ulcerated lump in this region, so the most likely diagnosis is basal cell carcinoma. Okay, if you have a butterfly-shaped lesion over the sternum, okay, these this is most likely to be a pillar. A pillar generally follows some sort of injury. But quite something. This is follicular death. This patient just had a tendency. So there's no history of an injury. It's a small, when it heals, can do the rest of this. This is the case we know to grow into the sarcoma. So this is the and this typical we have a study like this. Cysts we know develop at lines of fusion, along lines of fusion. It is believed that as the bones, you've heard of tectonic plates, right? When we so this is formed at the junction. So this is at one of the typical sites. The other sites are lateral canthus, Okay, so over the midline, various sites. So this is a retroauricular dermoid. Okay, again on the scrotum, okay, this is a adventitious bursa, okay, because these patients, you see more of these cases nowadays than when we were students, because what is happening is all these new professions are coming up. People are making parts for the IT industry. The small scale work is done in this what we call in slums, in the urban areas it's done in slums, or in the villages there are factories. So clothes factories and all these goods which are coming online, the smaller goods, making these false jewelry, so all this stuff is made by people, literally hundreds of people sitting on cement floors. So they're sitting in the cross-leg position and the lotus position, and what is happening is this constant irritation of the lateral malleolus, and you end up with something called a bursa. It's an adventitious swelling here, and this obviously you see a swelling in the front of the neck, in the anterior part, most likely to be a goiter. Okay, and again, this is the ganglion layer proper. So see, just seeing this, that doesn't mean you can't have a cystic hygroma here. Doesn't mean you can't have a melanoma here. Doesn't mean you can't have this is practically no differential diagnosis, because the appearance is so characteristic. But just to say that the site itself can tell you something about the diagnosis. Okay, again, this swelling was in the epigastrium, and the patient was having fever. And on examination, there was up and down movement. So obviously the swelling was arising from the left lobe of the liver, and it was a liver abscess in the left liver. Okay, this is just before operation. Again, these are lipomas. This can occur. So this is the counterpoint. Just as site can tell you something about what the diagnosis could be, again, some swellings occur everywhere. Okay, this is the ubiquitous swelling of the lipoma. This is over the back, and this is in the scalp. Okay, this can occur practically anywhere there is fatty tissue. Again, this looks like, first impression is it's a retroauricular, but that is misleading. Okay, this is actually a sebaceous cyst on the skin. So this is just to emphasize that don't overdo it. Don't think that anything in that region will be that particular swelling. Okay, this is just to show you that nothing is constant in our. That's the beauty and the difficulty of your subject. So on first sight you'd say, oh, this is a retroauricular dermoid. No, this is a sebaceous cyst actually. Normally this is swelling at this site is usually a external angular dermoid. Angular means at the angle of the eye. So external means lateral, outside. External angular dermoid. But actually this was a sebaceous cyst. So these rules are not absolute, but they are very helpful. Okay, size. An incision hernia will not be of this size. Won't be clinically visible. Okay, so an incision hernia, when it is visible, is usually quite large. Okay, this is a giant swelling, right? On the other hand, this is a congenital swelling due to the first arch defects. Okay, this is a branchial arch defect. The first arch, the pinna and everything arises from the first arch, and sometimes some remnants remain, and you get these small tubules. You must have seen people with these small nodules here. Okay, they are actually harmless. They are just congenital developmental remnant. So these rarely grow large in size. So the size also matters, and size can tell you something about the diagnosis. Okay, so see, you can have these small pituitary cysts. Okay, they are unlikely to become very large because the patient will notice them very quickly, and they will get them operated. The original gland from which the cyst arises is also very small, so this will never become very large. In fact, it will rupture, it becomes too large. On the other hand, this patient had filariasis. Okay, I operated on this patient 12 years ago, and this whole thing, this is the scrotum. Okay, the penis is lost somewhere here. Okay, it became slightly lengthened because of the traction, but this is actually the scrotum. Okay, it was practically touching the floor with the patient standing position. So you can imagine how large something can become. Okay, so size, even the size can tell you this will obviously not be a pituitary cyst or a sebaceous cyst of the scrotum.
This the whole spin is involved. It is taken. I'm not saying just the size will tell you the diagnosis. I'm just saying it is one of the factors. Okay, which help you in making a diagnosis. The shape. See, collards usually are classical. This is another collard, typical butterfly shape. See, goiters are butterfly shape. Okay, and this is the typical shape of a snake-like and tortuous typical shape of varicose veins. He has a tremendous case, a very advanced case of varicose veins. His veins have become totally like Hydra. I wonder how many of you watch these movies. Hydra was a character in Greek mythology. Okay, and he was finally, the head was cut off. You stare at her, you become, there were multiple snakes and on her head, and if you stare at her, you became a stone. So you had to cut her head off. I think it was Perseus. Sorry, I forget. Anyway, it was Zeus' son who cut off her head. So it's like that. See, all these veins are distended and dilated. So this shape tells you the diagnosis. As simple as that. This shape tells you the diagnosis. It's not just any bone scar, it's a collard. Okay. This is the goiter. Full stop. Okay. This is affecting the whole for thyroid gland, so it has taken this shape. So this is the goiter. So, and I leave you all of you to ponder what this could be. Okay. I would like some emails or WhatsApp answers from you. So we will end here. Thank you. Hello. Hello.
Yes, sir.
Yes, sir. Okay, so did you see all the pictures?
Yes, sir.
Yes, sir. Okay, so I'm expecting at least a few answers from you what that last picture could be. Okay, so we'll finish today and we'll continue the next Thursday. Okay?